Thanks, Angie. I'm Dr. Weigel, Dr. Dennis Weigel. I've been with Heartland, formerly Alexander Orthopedics, now for 23 years. This is our facility. We started out much smaller years ago. My task today, we're going to talk a little bit about arthritis and the treatment of them, particularly robotic joint replacements. And our group initially started back in 1974 with Dr. Dave Larson and then Dr. Terry Kennedy. And initially, there was just the two of them, and they did kind of the gamut of everything. And now we are five orthopedists. Dr. Dale just recently retired, and we have Dr. Lindley, who's a neurosurgeon, and Dr. Andrews, who does physiatry and work, and then Dr. Harvey, who's a non-surgical family practice doc who specializes in orthopedics. And we have numerous outreach clinics, Alexandria, Wilmer, Morris, Graceville, Wadena, and Fergus Falls. And just to kind of reiterate, we do cover the gamut of orthopedics, joint replacement, which keeps us very busy, particularly myself, but also sports medicine. We have physical therapy, upper extremity management, foot and ankle with Dr. Stika, and then the neuromuscular and back and neck care. And here's our mug shots. Myself, much younger, Dr. Weigel and Dr. Nelson, Dr. Balgard, Dr. Monroe, Dr. James Nelson, who's our newest orthopedist, and then Dr. Stika, who's our foot and ankle specialist, Dr. Andrews, who does the neuromuscular care, and Dr. Lindley, who's the neurosurgeon, and Dr. Harvey, as I mentioned, is our non-surgical physician in the clinic. And so, as I mentioned, I'm going to be talking a little bit about robotic joint replacement, and just to kind of get us so we're using similar terminology, I'm going to talk about arthritis, what it is, and kind of what the treatment of it is. And this is a picture of our robot. It's the Mako system by Stryker. And we've been using it at our facility for 4 years now, and it's been a wonderful advancement in joint care. And why is this important? Well, our joints are involved with everything that we do, and a painful arthritic dysfunctional joint results in significant disability and loss of function for an individual. And the whole goal in orthopedics, our mantra is really to keep people active and moving. So what is arthritis? Well, there's various different types of arthritis. The most common type of arthritis is rheumatoid arthritis. The most common type is osteoarthritis, which is about 80% of the cases that we see. And that's kind of wear and tear arthritis, where the cartilage wears out. Just not everyone has the same set of tires, if you will, when we're born. And osteoarthritis, the joints will wear out a little bit sooner than what we'd like to see. And numerous things can play into that. Then there's post-traumatic arthritis, which is what we'd call a secondary type of osteoarthritis, where the cartilage wears out from a mechanical derangement, either from an incongruency, from a fracture that involved the joint, or a malalignment or instability. And then there's the inflammatory type arthritic conditions, which rheumatoid arthritis is the most common type that we know of. And that's actually is a condition where the body actually attacks itself. The immune system attacks the joints, results in inflammation that then results in the same loss of cartilage. The end result is the same, but it's the pathomechanics that are different with that. Oops. So how do we get it's froze up for a second. How to get a proper diagnosis? Well, the first thing is you start off with a history and physical and the symptoms. When did they start? What sort of symptoms is the individual experiencing? Arthritic conditions involving the joints, particularly as you get farther along in the process, typically results in pain with weight bearing. A lot of times will be relieved with rest. And then as the condition gets worse, people will start to experience pain at rest, pain at night, swelling and whatnot. It's always important we take into account the patient's overall health condition and what are their goals, and that factors into what the appropriate treatment is. And then the examination to assess the affected extremity, and joints above and below can play into that and can play into the treatment. And so we'll assess that as well. And then the next step is imaging studies. And for most of the time, imaging includes radiographs, and x-rays will typically show us what we need to see 99% of the time. So here's an x-ray of a knee, and on the left-hand side of the screen, this is a normal non-arthritic knee, and you can see the outline of the end of the femur right here and the top of the tibia. And so the space between there, kind of that grayish shadow, that is the cartilage cap. And we like symmetry in orthopedics. Joints typically are symmetric, meaning that the space between the bones is of similar thickness throughout. Well, if you compare that to the x-ray on the right-hand side of the screen, you can see where these blue arrows are. If you look at the outline of the end of the femur and the top of the tibia, there is no cartilage cap in there. And there's actually a big osteophyte or a bone spur right in this area and on the end of the distal femur. So that is end of the line. That's severe osteoarthritis of the joint. Hip, similar concept. So this is a x-ray of the hip on the left, normal x-ray on the left, and you can see the outline of the acetabulum or the socket, outline of the femoral head or the ball, and once again, this shadow here, that is the cartilage cap between the bones. That's the tread on the tire when we use the tire analogy. When you lose that, that's arthritis, and that can result from either osteoarthritis, post-traumatic arthritis, or rheumatoid arthritis. Similar concept, similar end result is the loss of that cartilage, which results in pain, swelling, and disability of the joint. And so here's an x-ray on the left, or the right-hand side of the screen, that shows the complete loss of joint space. And you can see all the way throughout the joint, there is no joint space left. And this x-ray actually, if you look at this, you kind of get the appearance that this area is a little bit more white. The reason for that is in osteoarthritis, the bone that sees more stress in the area where the cartilage is lost will become harder. It'll develop a condition called sclerosis, which will result into that increased density in that area. So, you know, we always start off with the simple things, and if these take care of it, that is the preferred way to go. You always start simpler and kind of move up the treatment algorithm. A lot of times, by the time people come to see us, they have tried one, two, or all of these things. But early on, you know, diet and exercise is very important to maintain the overall health and strength in the affected extremity. Medications, typically the over-the-counter medications like Tylenol, which is pure pain reliever, or if people can take the anti-inflammatory such as Aleve or ibuprofen, and there's numerous prescription ones that can be tried. Joint supplements have been shown to have some effectiveness as far as like glucosamine and chondroitin and sulfate. And then rest and ice is helpful for periods of exacerbation of symptoms. And then physical therapy can be helpful to maintain range of motion, because one of the things that happens as the knee becomes inflamed, painful, is people will start to lose motion. They'll use it less because it feels better not to engage in those extremes of motion. That can result in stiffness that persists. Secondarily, it's important to maintain the strength in the extremity for overall function. And that's where therapy can be helpful as well, as far as alleviating some of the symptoms. And then finally, injection therapy. Injection therapy in orthopedics is primarily one of two things: corticosteroid injections or steroid injections, and the rooster comb injections, or what's called viscoelastic injections. And the rooster comb injections, probably not as effective with bone-on-bone arthritis. The main advantage of those injections is that when they do work, they can provide longer lasting relief. However, they're slower onset and less likely to work with severe arthritis. Whereas cortisone injections are more likely to work with severe arthritis. So those x-rays that I was showing earlier with the knee and the hip, both of those are severe bone-on-bone arthritis. Cortisone's probably going to be your best bet of trying to give some relief. The question is, how long is it going to work? So this is the million-dollar question we always get, is when to consider joint replacement. After I talk to a patient, I go through all the options and whatnot and talk about surgical versus non-surgical. Then a lot of times I'll come back and say, well, what should I do? When should I have my joint replaced? Well, the time to consider that is when you are experiencing significant disruption in your ability to engage in normal activities. It interferes with the things that you want to do, whether that's socially, professionally, whatnot. The non-operative treatment measures have not provided the relief that you'd like. And after discussing it with an orthopedic surgeon to make sure that this truly is the right diagnosis and the appropriate treatment measure. And then if people are on the fence, I encourage them to go home and talk it over with their family. It's a wonderful operation, but it's not something to jump into lightly, because there is some recovery associated with it. You need to be ready to engage in that. So the benefits of joint replacement is to get people moving. It is one of the more successful procedures out there. Hip replacement was judged the surgery of the century and has been one of the most wonderful advancements in medicine. As mentioned, the goal is to reduce or eliminate pain, restore mobility and quality of life. And that is really what we're looking at doing, is improving patients' quality of life. So kind of go over what a knee replacement is and what a hip replacement is. So we're kind of talking in similar terms. So on the left-hand side of the screen, this is a partial knee replacement. Now we think of the knee conceptually as having 3 different compartments. You have one on the inside, one on the outside, and then it's not really shown on this diagram, but there's a compartment that weight is borne through the kneecap area, which articulates with the front part of the femur. So in a full knee replacement, we replace all of those. Now, a partial knee replacement, essentially we're replacing or resurfacing 1/3 of the knee. And so you can see here, this is a metal tray with a plastic piece that sits on the top of the tibia, and we just take a little segment of the tibia away so that will fit in. And then there's a piece that runs on the end of the femur that articulates with that. We leave the cartilage alone on the outer portion of the knee and underneath the kneecap. So that is what a partial knee replacement. Now, total knee replacement, we're resurfacing everything. And replacement's probably not a great term. Resurfacing is probably a better term, because essentially in both of these operations, what we're doing is removing the worn ends of the bone. We're leaving the ligaments on the side of the knee in both instances. In the partial, you have to have an intact ACL and PCL ligament. So these are what we call the cruciate ligaments, which are in the middle of the knee. And in a full knee replacement, the cruciates are less important. A lot of times the implant will take that up, but sometimes when I'm talking about a total knee replace, people think, well, we're taking this large segment off and putting this large hinge device in. It's actually basically we're putting a new cover on the end of the femur. So now this is what a hip replacement looks like. And so a hip replacement, similar concept, we're replacing the arthritic surface with prosthetic materials. So the hip is a ball and socket joint, a little simpler mechanics of the joint, but you get a cup that fits into the pelvis, and we prepare that old socket. We get back to bone that will grow into that. So if you look at this, you kind of get a sense that there's some texture to this cup. This actually has a ingrowth surface that the bone will actually grow into. And once that grows into it, it's very stable. They tend not to come loose unless there's something significant going on, such as an infection or whatnot. And then on the thigh side, we take off the old ball. We'll make a cut on the end of the top of the femur, and that gives us access to the middle of the bone. And we'll put this stem down, and that stem similarly has a substrate on the top part of this proximal part of the implant that the bone actually grows into. And most hips put in these days are what we call uncemented, or the bone actually grows into. And they have some definite advantages as far as durability, because you don't have to worry about a cement mantle coming loose and whatnot. We still use cement on certain circumstances, but that's in people who have a really soft bone or really poor bone that we just can't get good fixation with this. And so then those are the implants that actually adhere to the bone, and then we need a bearing surface. So this plastic piece actually fits into the cup. So that becomes the new socket, and this head articulates with that, and this head actually impacts and fits onto this taper, the top of the stem. And so the articulating surface is between these two implants. So risks and complications, like anything else in life, there's always pros and cons, and nothing's without a potential downside. And both hip and knees are very effective, very successful operations. and 98, 99% of the time, everything works out well. But there are some things that we worry about, and these are kind of the top four that are pretty significant. Infection, not very common. It can happen. Can be between 0.5% to 1% risk. If you catch it early, sometimes we can clean them up surgically in 6 weeks of IV antibiotics. If it's more advanced or bacteria that aren't really amenable to treatment with antibiotics only, sometimes we have to actually take the implants out, put in a temporary spacer with antibiotics, and then clear the infection, then put a new implant in. Blood clots, we put people on blood thinners and get them moving right away to try to minimize that. And loosening and wear, much less common than they used to be. The implants and the materials are so much better. This was a bigger issue back in the 90s when I was in training. Now the kind of the more likely reasons for infections, loosening we'll see some, but infections and instability can be issues. So we've been running the Joint Replacement Center since around 2008 or so, and it's been just a wonderful addition as far as providing care to our patients. We've done over 7,000 joints since 2008, and it's really provided excellent satisfaction for the patients. We've been able to get people moving quicker, back home more often than what we did. When I first started in practice 23 years ago, I bet probably 30% of patients went to a nursing home. That was just kind of what they did. And now we try to get people home, and because people feel better at home, they recover better at home. And certainly there are folks who don't have the capabilities or the resources to go home, and so nursing home is still an option for those folks. But the goal is to try to get people back and get them back into a healthy lifestyle situation, and getting home is part of that. Similarly, the length of stay in the hospital has gone down over the years, and average length of stay is around 30 hours. And in some circumstances, we are doing outpatient total joints. Once again, not something that's for everybody, but in the right circumstance, it has been a positive for folks. So this is what the robot looks like, and it's certainly not what you envision a robot in scientific terms or science fiction terms, but basically this is a device that hooks up to a computer, and this arm up here is kind of the working portion. And it allows us to do a couple things. On the hip replacement side, it allows us to very accurately put that cup in that I was showing earlier. We can put that in if we say we want it to be 40 degrees off the horizontal and 25 degrees facing towards the front, what we call anaversion. We can hit that target every time. Whereas with manual techniques, the studies on those, you could miss the target up to 20, 30% of the time, depending on patient's anatomy and whatnot. So those surveys did very well, but if we're trying to hit a goal, we should try to hit that as best we can. And so this robotic arm has assisted in that. The other thing, as far as on the hip side, is it allows us to very accurately measure leg length, which is one of the potential complications with a hip replacement. Doing what we call a manual total hip, the older way of doing it, where you don't have a fancy $1 million tool such as this. I would tell patients, listen, if we're within a centimeter of leg length, that's kind of the tolerances, because there wasn't a great way to really assess leg length before and after. We would take measurements, but there are a lot of factors that played in. So there could be some lengthening issues because we're balancing off muscles. With the robot, we can, detect 1 to 2 millimeter differences. And so I think patients have less of a tendency to feel like the leg is long compared to the operative or preoperative situation. And then on the knee side, we can really tweak how the implant goes in according to the patient's anatomy and ligament tension. And I think that's translated into knees that feel a little bit better for the patient. And then the other thing that we don't have to do is I don't have to instrument the bone as much. So I think the knees tend to swell up less than what we consider a manual total knee. And I'll talk about that a little bit more as we go on. And so, as I mentioned, the satisfaction with this has been really quite overwhelming. I think people are getting better. The implants are going in more accurately. We're doing a better job of recreating what we should be trying to recreate. And I think that has shown up in the satisfaction surveys and whatnot. So how does it work? Well, when we plan these out, we get a CT scan preoperatively, and that allows us to develop a very detailed surgical plan. And you can see this up on the upper left-hand side. So this is what we'd see on the knee side, and we can take some preliminary planning based off of numbers as far as how much bone we're planning on taking off, whether it's 5 millimeters, 8 millimeters, whatnot. And then we compare that once we get in there and check that, and we can tweak that plan based off of patient's anatomy and ligament tension, which has been the next phase of this type of surgery. We've had what we call navigation, which are image-based systems previously that allows us to develop preoperative plans, but the problem with those is those were static studies. They did not take into account for ligament tension, and so if somebody might have a tighter MCL, the inside knee ligament, you still have to kind of mess with that and release that to balance that out. Whereas using the robotic system, we don't have to do those soft tissue balancing trade-offs as much. And then on the hip side, similarly, we get a preoperative plan. You can see this is the plan with the cup going in the pelvis. We've taken off the top part of the femur. This is the right hip, this is the left. So we take the top of the femur off, get rid of that ball. That gives us access to the cup, put the cup in, gives us access to the end of the femur to put the stem down and a new ball. And then we can assess how much length are we getting, how much we call offset, which is basically the lever arm that these abductor muscles have to work off of. And then we get these preliminary plans, and once we get in there, we kind of finalize things based off the anatomy. On the knee side, we remove, once again, we're just removing, probably between 2 to 10 millimeters of arthritic bone off the end of the femur and top of the tibia, and just a way to realign the leg and to have enough room to put an implant in. And then this is a hip diagram of us putting the cup in, and you can see how the robotic arm attaches to that and basically acts as a very sensitive instrument to measure those angles and where we're putting the cup at. And as I mentioned before the surgery, we get the CT scan, and this is just another picture of the knee. And so you can see this patient, after we have the implants in, we've got 2 degrees of varus. Pre-op, we're planning for 0 degrees of varus, which means we're getting them neutral. And then the flexion. So we get with this patient's able to get the knee out straight. And so when we're doing these gaps, we want to have these numbers balanced, and we'll tweak these to get these balanced out so it's as close, if not 20s on both sides. And one of the things that as a surgeon was a little bit humbling to realize that when I thought I was feeling 2 millimeters of gap, probably wasn't 2 millimeters of gap. Our hands just aren't that sensitive, and this robot is just an incredibly powerful tool for assessing that. And the basic premise of a knee replacement is you want to be able to put back what you take in and have these knees balanced with the knee out in full extension and with the knee bent 90 degrees. If you have those numbers balanced, these implants are designed to function very well. And the robot helps us hit that target. Once again, this is another image of what we do with the robot on the hip side. So this is a CT image looking at the hip from the front and looking kind of cutting the person in cross section, what's called an axial cut. And so this green represents the cup. And so we can move this based off of optimal coverage and to restore the center rotation appropriately. And based off of this, when we decide, okay, this is where we like the cup, that robotic arm not only sets the angle, but will also set the depth of our preparation, or we call the ream of the bone. It won't allow us to go any farther. It will shut down if we try to do too much or whatnot. And same thing on the knee side, which is a nice safety feature there. And so once again, if I want to get this 20 degrees or 40 degrees off the horizontal, I can dial that in, and 20 degrees of anteversion, which is this angle in relation to this plane, and we can hit that. And then after we put the cup in on the hip side, we have the stem, and then we can adjust things and make sure that, we're getting our leg lengths where we want them to be. So these would be the numbers for the operative leg and the non-operative leg, and you try to get these as close as possible. And then this is what's called the offset, which is the tension on the muscles, what's called the abductor muscles, which run here. And those are the muscles that are very important. They're the ones that allow you to walk without limping. And so you want to get those restored as appropriately as possible. Once again, just another image of the hip, what it would look like. And then it's actually pretty neat. They can actually give us a screen where, and what's called an X-ray view, and what it would look like with the implant in. And it's pretty amazing. Once you put that in and you take a post-op X-ray and you compare it, you pretty much are predicting the future with this technology. And this just kind of reiterates what we're doing as far as the bone preparation and whatnot. And this is kind of what the arm looks like. It attaches to the instruments that we normally use anyway with a joint replacement. It's just a very accurate guide. And so it's been a pretty seamless transition. It's not like we're really learning a new procedure when we start using this. It's just another tool that goes in the toolbox. And so then this is kind of what we look at afterwards. So this would be what a hip replacement looks like. This is what a partial knee replacement looks like. And this is what a total knee. So once again, kind of going back to the implants, this is the stem that goes down the middle of the bone on the total hip. Here is a ball, and that fits in this cup. And so the new articulating surface is right here. Similarly, on the knee side, this is a partial knee. So you got a metal piece on the end of the femur, a metal piece on the top of the tibia, and you can see the joint space in here. So the plastic does not show up, and because we're getting a good tangential view of the joint, you'll see that clear space, and that's the plastic. Knee, similarly, you see the plastic sitting here, and so this is a metal piece on the end of the femur, metal piece on the top of the tibia, and the plastic is this black area that sits in through there. The hip, you don't appreciate that as much because of the geometry of the cup, but basically this joint space when we're looking for where we're kind of looking for any changes in thickness from here on this top part or superior part of the cup, because that's where that will show up. So what are the differences? Well, between a traditional and robotic? Well, same incision, you still have to put an implant in, you still have to get access to the bone. But there is less soft tissue balancing on the knee side. And that I think is translating to less soreness, less swelling in the joints. And then once again, I don't have to instrument the bone as much. And one thing in particular, when we do a manual knee, we would have to reference off the axis at the end of the femur somehow. And so we would actually put a rod up the middle of the femur. Well, what's in the middle of the femur? Marrow contents, and marrow will ooze and it'll bleed. And so I think the knees tend to swell up much less using the robot, because I don't have to violate that bone as much as I would with the manual technique demonstrated here on the right. And as I mentioned, it's a very accurate tool, so it allows us to very accurately prepare the bone and restore alignment. And studies have repeatedly demonstrated that. So here is a surgical video.
Our knees are the largest joints in our bodies. They're central to almost everything we do. So if you or a loved one is suffering from arthritis or an injury to the knee, everyday activities such as walking, sitting, or kneeling can feel debilitating. But you're not alone. It's one of the nation's most common causes of disability and impacts the lives of 54 million people in the United States alone. One possible treatment option for knee pain is total knee replacement, a procedure that involves removing the damaged bone and cartilage, then replacing the knee joint with an implant to reduce pain and restore the motion and function of the knee. Today, knee replacement surgeries are being combined with a new technology, and it's changing the way knee pain sufferers are treated. Meet Mako, a robotic arm-assisted technology used by surgeons to perform total knee replacements. This unique technology helps surgeons provide a personalized surgical experience. where each surgical plan is based on a patient-specific diagnosis and anatomy. And in a laboratory study, Mako Total Knee enabled surgeons to execute their plans more accurately, while also protecting soft tissue and ligaments from damage. Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of X-rays taken at different angles that can help surgeons see things that they can't typically see with an X-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
Okay, so that was a pretty nice demonstration of what the surgery involves. As I mentioned, the goal is to get you back doing activities and enjoy life again. And so, these joints are designed for low impact type activities. I tell folks basically the only thing I would recommend is don't take up marathon running. Walking, biking, swimming, golfing, dancing, pickleball, all those things are fine. But the running I would worry about. And mention the goal is to get you back to do what you like to do. So in summary, the key is to come up with the proper diagnosis. Sometimes we'll see people that will be referred in for hip and knee problems, and maybe it's not coming from that joint. Maybe it's coming from their low back or whatnot. Arthritis can be controlled. There's many different options from non-operative to operative treatment. And if folks do choose joint replacement as a very successful operation, typically people are, I tell folks 2 to 3 months, you're typically back doing most everything again. And we've been pretty fortunate to have this technology and offer it to our patients for the last 4 years or so. And it's been a wonderful advance as far as adding to the success of joint replacement. Thank you.
That is the end of our PowerPoint presentation here for this evening. If you have any questions, you can certainly add them to the chat box, which is on the bottom of your screen. You can type that in. Otherwise, if you have a question for Dr. Weigel, you can unmute yourself, which you can see that microphone button should be on the lower left hand of your screen potentially. And you can go ahead and fire away. Thank you for attending.
I do have a question.
Yeah.
For Dr. Weigel. You mentioned leg length discrepancy. If you have a known pre-existing leg length discrepancy, is this able to be corrected with surgery, whether it is or isn't the affected side?
So there are some limits to that. So the easiest issue to deal with is if the operative leg is shorter. And the reason for that is when we're doing a total hip, we're balancing off the muscles. And so the more stretch in the muscle, the more stable the hip. So if somebody has, say they're having their left hip replaced and their left leg is, maybe an inch short, we can address that. We can deal with that. It's a harder problem if that left leg would be longer than the other side, because you do run the risk, if you shorten the leg, you have less stretch on the muscles and you could end up with an unstable hip. And so there are some limits to that. And the other issue would be if folks have a significant leg length, you start running into issues with maybe putting too much stretch on one of the big nerves called the sciatic nerve, which runs down the backside of the hip. And you can run into problems with maybe having that nerve not work properly, which would result in weakness in the foot. So we can, 99% of the time, we can deal with it. Probably the hardest issue that I'll run into is if somebody has a long leg and they want it shorter. It's hard to fix that. It's actually an easy issue. If the other leg needs to be replaced, then we can address that appropriately. So.
Okay, thank you.
Yep.
There was a question in the chat box. I don't know if you want to
Sure.
just read that off.
So the question is, if both knees are affected, is it recommended to both at the same time? That is a individualized question. In the right circumstance, if somebody's healthy and both knees are equally involved as far as symptoms, and person's clearly motivated, it's certainly an option. I wouldn't do it just because they're bad on x-ray and one hurts and the other one doesn't. In that circumstance, I always treat it based off of the symptoms. Our whole goal is not necessarily to make the x-rays pretty in our eyes, but to help somebody be more functional. So if they're equally painful, then yeah, I think it is an option. Certainly there's some downsides. It's harder recovery. You don't have one knee to focus your energies on. But yeah, it's certainly an option. Any other questions?
I have a question. Can you hear me?
I can hear you.
Okay. I had my right knee replaced about 5 years ago, and I think I'm ready for my left knee. The right knee, I think I had to spend 3 days in the hospital for that. You said the hospital time is reduced by quite a bit because of the robotics. Also, I'm wondering about the pain level. Is there less because of the there's less tissue, soft tissue damage and so forth? Is it a quicker recovery?
Yeah, I would say on an average, yes, it is a quicker recovery. There is less soft tissue damage. There's less swelling in the knee, which I think translates into early recovery. The anesthesia techniques have gotten so much better too. The blocks and whatnot that we're utilizing, our anesthesia colleagues are utilizing, tend to get people through the worst portion of it early on. So yeah, I think it's multifactorial why people are getting better quicker. It's anesthesia, it's surgical technique, it's rehab protocols. 20 years ago, I can remember people being on what's called a PCA pump, which we don't use much anymore, where they would hit morphine, hit the pump to get a dose of morphine, and they would kind of zonk out, and then they might get sick, and they'd wake up, and then they'd hit the button again because they were in pain. And they would struggle to get the knee bent to 90 degrees. And, today, you have the joint replaced in the morning, we'd have you sitting up on the edge of the bed, bent 90 degrees that afternoon. People are bouncing back quicker than they were, even a few years ago. Yeah.
Do they still have the therapy sessions in groups like they did a few years ago? After the surgery?
Yeah, Let us come back after COVID. Yep.
Okay. Okay, thank you.
You bet. Oh, couple questions. What type of pre-therapy do you recommend prior to hip replacement? You know, it depends on the individual. Patients do get instruction as far as what they're going to be expected to do after surgery. You know, people who might be a little more debilitated, certainly some pre-operative therapy can be helpful. It's kind of like training for a big event. The better condition you are in leading into it, the quicker you're going to bounce back. Let's see. How soon do I need the CT scan? So the CT, generally, if it's done within a week, we like to have it a little bit sooner, but if it's done within a week, we can get it taken care of without much issue. We have had a few circumstances where they had to have it done because of a fracture or whatnot, and that can be turned around pretty quickly. It can be a challenge though, so I would say generally within a week would be probably the minimum that we'd like to see. Let's see. Another question. How much bend is expected post-knee replacement? Greater than 90 degrees? For sure. You know, we like to have as much as possible. You know, to some degree, the motion that you have prior to surgery dictates the motion that you're going to have afterwards. Knee average range of motion is probably somewhere around high 100 teens to 120, depending on the individual. You know, it's we want to also get it all the way out straight too, and that's also important. Sometimes people focus so much on the bend that they neglect the extension, and getting out fully straight is also important for being able to walk effectively. As far as anesthesia, do you use general anesthesia? We do not. Probably 99% of our joint replacements are done with a spinal block, so they numb the legs, and then they do the post-operative nerve block. Probably the only scenario that we do use a general is only if people have had pretty significant spine fusions and they can't get a spinal in. Definite advantages of the spinal: they tend to be safer. They allow people to be more awake, less nauseated, and they do a better job as far as pain control. So yeah, we try to avoid general anesthesias and intubation. So I hope that's reassuring there. Any other questions out there?
Doctor, I got a question. If the diagnosis is a partial knee surgery, has there ever been times where you've had to go back and then do a full knee surgery afterwards?
Rarely. And that is that is the potential downside of that operation. Partial knee replacements came around back in the 70s, and they actually had a little bit of a bad reputation back then because they were put in without really good clear-cut indications. You look at charts from patients from the 70s, then they'd have a partial knee replacement for rheumatoid arthritis, which would be a pretty clear contraindication. If you think about rheumatoid arthritis, it's an inflammatory process that affects the entire joint, as opposed to osteoarthritis, which is a mechanical issue that affects only one portion of the joint. So, it can happen. I try to be pretty conservative about partials. Their partials, probably in this country, maybe around 8% of knee replacements. There are some folks who say that, will argue that maybe 20 to 30% of knee replacement patients overall would be candidates for partials. I think that's a little bit aggressive. I don't like operating twice if I can avoid it. And so I tend to be pretty conservative on who gets partials. And I think the gap is narrowed actually using the new technology. So there's pros and cons of both. Let's see. Got a couple other questions here. So our hip replacements typically outpatient. Depends on the individual. People who are healthy and have good support at home, I think hip replacements are probably a little bit easier to manage on an outpatient basis. Hip patients tend to bounce back pretty quick. They feel pretty good, but certainly not for everybody. If somebody's pretty debilitated going into the surgery, doing an outpatient total joint, probably not the best choice, and at least spending one night, or if somebody has a cardiac history or something like that. So let's see. How long after surgery is the blood clot risk heightened? So highest risk is usually in the first 6 weeks or so, certainly in the first month. You know, I think we're less aggressive with anticoagulation than we were 30 years ago. Some of that is people are treated differently. You know, if somebody does not have a history of blood clotting issues or a family history of blood clots, you know, a lot of times we use aspirin. Less risk of bleeding, a little bit safer, you know, because there's pros and cons. We could put folks on more aggressive anticoagulation, but does increase the risk of getting a bleed in the surgical site and what's called a hematoma, which can be painful and whatnot. And we get people moving right away. Whereas, you know, when I was a resident, people had surgery and they'd sit in bed for 36 hours before we got them moving, because, you know, at that time we just thought, oh my goodness, this person just had surgery, they can't move, and now we get them up moving that day. So any other questions out there? I ran out of my list of chat questions. Okay. Oh, the one. Oh, what level is the spinal usually done at? Well, it's in the lumbar spine. I think it's between L2 and L3, if I remember right. I don't do the spinals. I'm a little bit removed from that, but that's my recollection of the technique. I haven't put a spinal in for about 25 years, so you don't want me to do it. We have anesthesia folks who do those, so. Yeah, very good questions. Okay. Well, I think that's it. Unless somebody else has another question. Thank you very much for attending. This has been fun.
Thank you.
Thank you.
Thanks, everybody. And if you think of questions after the fact, I think most of you have my email. Again, it's amiller@alamerehealth.com, or you can contact Heartland Orthopedics. So again, thanks everybody for joining on our inaugural virtual seminar here. So we'll have more of these in the future. Thank you.